Hi, this is Dr. Bob Dannenhoffer, the Public Health Officer for Douglas County. It's Friday afternoon, a beautiful Friday afternoon, but not beautiful as far as COVID goes. I'm in the room all by myself, so I can take down my mask, which I'll do, and hopefully you can hear me well. So this is a chance for us to answer your questions. We have a great team working on this here. We've gotten a bunch of questions through Facebook Live, which we'll do first today, and then we'll go on to the questions we get during the discussion. So as always, we start off at the beginning with the worldview and then move down. And indeed in the world, it's really grim. 57.5 million cases, 1.37 million deaths. More than 500,000 cases every single day and more than 10,000 deaths per day. Still a very active pandemic in the US, India, Italy, Brazil, Poland, Germany, Russia, and the UK. Although, let me tell you that it's been these countries all for the last 5 or 6 weeks that have all been really busy. And when you look at this, the US case counts continue to rise very steeply. But in India, Brazil, Poland, cases are down over the last few weeks. In Germany and Italy, cases are flat. And in Russia and in the UK, they're still rising, but they look like they're past their peak. So really, at this point in the world, the US is the only big country in the world that still has this really steep rise. And this is very worrisome. And there was many cases yesterday in the US, is in those 7 countries combined. They've got a population of 2 billion. We only have a population of about 330 million. And so we have a really high rate. This also in the world, there's another 2 billion people in the world in the countries of China, Australia, South Korea, Japan, Hong Kong, Singapore, Taiwan, that have about 2 billion people, and they're having less than 1,000 cases in a day. So, this is a bad time, bad pandemic, bad throughout the world, but really the US is the only big country where it seems to be bad and getting worse. In the U.S., we have 12 million cases, 258,000 deaths. Yesterday, we had, depending on which source you use, about 190,000 new cases, and it looks like today may be worse. We had 2,065 deaths, which means that we had more than 1 death every minute. And so what I tell people is that gatherings lead to cases, cases lead to hospitalizations, hospitalizations lead to deaths, with about a week or 2 between each of those things. So you'll remember starting in October, we started seeing an increase in cases. Towards the end of October, we started seeing an increase in hospitalizations. And now we're seeing a real increase in deaths in the US. So 258,000 deaths, adding 1,000 or 2,000 deaths every day, we're likely to hit the really grim milestone of 300,000 deaths by the end of this calendar year. It's really widespread. There are 42 states with more than 1,000 cases, and really only Hawaii seems to have this under control. Alaska, which previously did, now has a bunch of outbreaks. Maine, which really has this under control for most of the time, has also started to have lots of outbreaks. The states in the U.S. where it's most is to be no big surprise: Texas, Illinois, California, Florida, and Michigan. So Oregon is sadly following this trend. Now we're following this trend, but at a lower rate than these other states. So Oregon reported today over 1,300 cases. Yesterday we were over 1,200 cases. This would have been unimaginable 2 or 3 weeks ago. But 1,200 cases yesterday, 1,300 cases yesterday. Yesterday there were 20 deaths. This is everywhere in the state. There's almost no place in the state except for the tiny little counties in the middle of the state where this is not active. The reproductive number, that is the number that tells us how fast this is rising, is 1.16. We, for a while, were under 1, which meant that the cases were actually going down. Now at 1.16, they're going up. And the hospitalizations are 411. Now, there are a lot of hospital beds in the state. So it's not like this is totally overtaxing, but the increase in the number is striking. And it wouldn't be surprising to me if we were at 1,000 hospitalizations by next week. And at 1,000, it really will start to show cracks. mostly because it's hard to get enough people to staff these beds. In Douglas County, we're at 788 cases, 15 deaths. We had 3 deaths just yesterday. I mean, we went months and months with very few deaths, and then 3 deaths in one day. Mostly older people. Some died at home, some died in hospital. But still, these were all people who were well enough. One of these people was somebody who went to the Halloween party, so they obviously felt well enough to go to the Halloween party on Halloween, and now they're dead. We have over 30 outbreaks in the community. These are workplace, gathering, church. Curry Manor seems to be the area here where we're having the most now. We had 36 as of this morning, and we just got a bunch in just as I was leaving the office. So we're likely over 40. These are all really old, sick people. And so we're worried about further hospitalizations and deaths from that group. With this many cases, we can't do the same kind of stuff we were doing before. Before, we were doing very in-depth interviews that lasted an hour or more. We were gathering all of the contacts, calling all of the contacts. And at this point, we're getting so many cases in that we're doing the best we can to triage the cases we have. But it was 28 cases before noon, and then another dozen or so cases this afternoon. That's a lot of cases to deal with. Protective equipment, or PPE, is getting short, and it's getting short because each of these patients that are in the hospital, the 411 patients in Oregon, the tens of thousands of patients in the U.S. that are in hospital, require an enormous amount of PPE. So the way this works, you have masks and gloves and whatever else, and every time you go from room to room, you take off the old and you put on the new, and sometimes for a really sick patient, you'll need 20 or 30 full sets of PPE for each patient. That's a lot of PPE, and it's so dependent upon the number of patients you have. Because for other patients, nurses do wear masks and gloves, but you use them at a much lower rate than somebody who's got COVID. Testing is actually getting better now. We have the Binax Now testing, which is great and has been really quite quick and seemingly really quite accurate. And the best news of the entire month has been the vaccine. So both Pfizer and Moderna have released results of their mRNA vaccines, and we'll talk a little bit more about mRNA vaccines, and they seem to be great. So these are tiny bits of genetic material encased in lipid nanoparticles that get into the cell. The cell then makes protein, the body then makes an immune response. And, we would have been happy at 50%, but both look like they're over 90% effective. And we had talked early on about safety signals. That is sort of cases that you think, could that have been related to the vaccine? And those are especially seen with the AstraZeneca and the Johnson & Johnson vaccine, but there have been 0 safety signals from the Moderna or the Pfizer vaccine. So it looks like with no safety signals and really good efficacy, that these are on the fast track for getting approved, and I think that is going to be a great thing. All right, let's get to some questions. So these are the Facebook Live questions we have that people wrote in. They wrote at Facebook questions at douglaspublichealthnetwork.org, and we get them. So someone said, I just read the comments from Archbishop Sample critical of the governor's freeze for churches. So I was curious about what my reaction would be. I'd like a good argument to maintain caution to all churches. I too would like to return, but I'm 75 and care for my 95-year-old mom, all with high-risk conditions, and I'm unwilling to take the risk. Pauline asks. So there's nothing special about churches. So whether it's churches, bingo, work, anytime you're with people for a long period of time, close together, and the more people you get, the more likely you're going to have an event that spreads the disease. So here I am sitting alone in this office. The chance that I'm going to get it from somebody or give it to somebody else is pretty darn low. However, if we did, like sometimes offices do, where you'd have 20 people in a room, all at desks, that would be really high risk, because of that 20, the chance that one person in the room would have disease is not very high, but it may be 1 or 2%. And if it's 1 or 2% and you're in the room together for long enough, and that person is contagious, there's probably a 0.5% chance overall that you're going to have a super spreader event. Well, that's not very likely, but if you did this enough times, right, if there are enough offices in town or enough churches in town, one of those could wind up to be a super spreader event. I will tell you that just this week we have a number of church outbreaks. And so churches are near the top of our list this week for outbreaks because people tend to be there for a long time. They tend to be closed. They may sing or do other kind of things that would spread it. So I think it is really worrisome. And churches, though, closing churches is very, very hard. And I know the governor did not do this lightly. I know from my mom, she's attended Mass before this every day for I don't know how many years. And church was for her a place of great religious comfort, as well as she had friends who were there and sort of got her out for the day. She didn't have much else to do in the day, so she would get out and go to church, and it was part of the daily routine, and this is one of the things that she has missed the most. But the concern is that if there is an outbreak at a church, it's likely to affect many people, and if it affects many people, then, you know, if you're 75 and you've got a 95-year-old mom with underlying conditions, you could easily wind one or both of you in the hospital or kill one or both of you. And so the question is there an alternative? And so my mom goes to the TV church every day. You know, not quite the same as being there, but it really is for her. It doesn't get the friends, but it certainly gets the religious stuff that she needs. I mean, I think I would worry about going to church with other people and the risk for that. And I really wish the Archbishop would keep his mouth shut on this. Keep his mouth shut on this. So Jeremiah has a question about positivity. And so test positivity is very controversial. So test positivity in general means of all the tests that you do, what % are positive? Now you can imagine if there was a lot of disease and you weren't doing a lot of tests, many of your tests would be positive. So when we look at states like South Dakota or Idaho, 50% of their tests are positive. What we've known through this outbreak and through other outbreaks is that when you test, the best predictor of you getting this disease under control is a declining test positivity. And that declining test positivity actually is a leading indicator. It happens even before your cases go down. And so if you remember, we had a little peak here and then a summer peak. And at the end of the summer peak, we'd gotten the cases really low, 3 cases in a whole week. That was almost under control at that point, and our test positivity at that time was less than 1%. So I think if there was any one thing for me to follow, it's test positivity, because an increasing test positivity suggests you're going to have a big problem, and decreasing test positivity suggests that you're getting this under control. So positivity is really, really important to do. Now, test positivity is, you would think it's easy to measure. It's really complicated. I saw a PowerPoint presentation today, about 30 slides, and I will tell you my brain was tired after doing it because it looked at all the different scenarios. Because the question is, how long do you consider the person positive for? How long do you consider them negative for? How long do you go back? Oregon has used the most conservative method in the past, which is you go back to the beginning of time. And if you're negative, you don't get count. If you're negative once, even back in March or April, your new test in November doesn't get counted. That's the most conservative way to do it. It gives you the highest test positivity rate. But it is one of the acceptable methods, but almost no other state is doing it. It makes Oregon now not very comparable to others. So Oregon is going to use a different method that most of the states are using, and I think it'll be a good one. Our test positivity now is over 10%. And it's likely to stay over 10% until we get this under control. And so I'm going to be following the test positivity rates very, very, very carefully. So Linda says, would you address the difference between antibody tests and antigen tests and PCR tests? Yep. She said there's a bad rumor that's spreading that all confirmatory tests pick up other coronaviruses, so our numbers have to be skewed. Okay. So the PCR test is a test done for somebody who's acutely sick or carrying the virus. It looks for small parts of the RNA that's in this virus. is a very difficult test to do. It's not a test you can do in a local lab like this. And if done correctly, it's remarkably both sensitive. It'll pick up even down to just a few copies of the virus in the sample, and remarkably specific, meaning that if it says you have it, you almost certainly do. The advantages of PCR tests is that they are so sensitive and they are so specific, but the disadvantage is really expensive. Probably costs $100 or so to do at the minimal cost. It requires lots of reagents that are in short supply. It requires million-dollar machines to make this work. And because they're done only in a few places around the country, relatively slow to get the answers. Now, there are single-gene PCR tests, which are not as good as the 3-gene PCR tests. And those would be like the BioFire or the Abbott ID Now or the Cepheid ID. Those are faster. You get those results in an hour. But they have a much higher rate of false positives and of false negatives. Antigen tests look for the proteins that are on the surface of the virus that now are in your nose, and you swab and look for the proteins. So the PCR looks for genetic material. The antigen tests look for protein. They are much faster, much cheaper, less than a few dollars, and much more available. We have boxes and boxes of these here, and much more available, but they're both less sensitive and less specific. The third kind of test is the antibody test. So the antibody test is a blood test, and it looks for the antibodies, those little particles your body make that fight infection. So they're not positive during the time you're sick, but get positive later and can stay positive for weeks or months later. So I give blood all the time, and one of the things on my blood donation they send you is we tested your blood for a bunch of things, and we tested your blood for COVID antibody, and you were negative. So the last 3 I've given would have been negative. So that's the antibody test. The antibody tests are useful if you were sick and couldn't get a test at the time because there weren't tests available or for whatever reason you didn't do it, to tell if you had the disease in the past. The antibody tests are useful if you want to give convalescent plasma. And the antibody tests are useful for nerds like me to want to know how much disease is in the community. So when you talk about, building up herd immunity, you have to measure how many people have antibodies. In Oregon, it's only about 2 or 3%. And the way they do that is by antibody tests. Some places in the country is as much as 20%, like in New York. So that's what antibody tests are used for. So getting back to your question here is about the rumor that all the confirmatory tests pick up other coronaviruses. No. In fact, that's one of the things they specifically test for on the PCR, is that there is no cross-reactivity with the other known coronaviruses, and there's not. Now, on the antigen test, there's the possibility that there could be, but they tested for that and haven't found it. So that bad rumor is exactly that, a bad rumor. So Bruce says, can you point me in the direction of any long-term studies on health risks associated with messenger RNA technology? I know this is the first vaccine, but it has been used in cancer treatment, correct? Are there any data on long-term risks? No. So messenger RNA technology. So here is if you slept through this part in biology, or like me, you went to school at a time when we didn't really know any genetics. This is the Bob Dannenhoffer quick approach to genetics. So there's DNA. Everybody knows about DNA. DNA are, people call the building blocks, but it's really the instruction manual for your body on how to do this. The way I think of it is there are 23 pairs of chromosomes. Each one of the pairs of chromosomes is like an encyclopedia. So imagine a bookshelf lined up with 46 books, thick books. Men have an X chromosome and a Y chromosome. Women have 2 X chromosomes. And somehow your body knows how to read them and not get confused and make a human being. It is, to me, the most amazing thing of all times. So that's what DNA is. What messenger RNA is like a scratch pad that takes the instructions from one part of the DNA and then gets in the cells and says, make this special protein. There's a bunch of different RNAs, but the one that this is something called messenger RNA, or mRNA, which I think is where they get the name for Moderna, which is one of the companies that are making this. So messenger RNA is like the little scratch pad that tells you what to do. What I was thinking of is actually more like a rubbing. So if you've ever done a rubbing on a gravestone, it's actually more like a rubbing because it is a fairly exact copy, or the mirror image copy of what the RNA or DNA shows. So messenger RNA, in this case in the vaccine, it's coated in nanoparticles. Again, nanoparticles, incredibly little tiny particles, and then kept at a super low temperature. So if you ever had Dippin' Dots ice cream, think of that, but a billion times smaller. And so these tiny little nanoparticles are injected. They get into the bloodstream. They get picked up by cells. The cells say, oh, here's a little sticky note that tells me to make this protein. The body makes this protein. It releases the protein into the bloodstream. The immune system says, oh my God, this is a new protein. We don't know what this is. We better get rid of it. And so it makes antibodies against this new protein. It's really complicated. I mean, it's hard to believe that all of those steps work, but it does. And it does seem to work very well here to make this work. And the question is, what's the danger of this? We've been using this for cancer for a while, and so for cancer for a while, you can do these nanoparticles with mRNA, and then it tells cells to make protein, and it helps to fight things. But most of those have been tried in just a very few, very sick patients. And so it's a little hard to know about safety studies when you're talking about cancer stuff. I mean, there's so much else going on in cancer. People, they're getting sick and dying, and there's usually just a few of them. And so long-term safety studies for mRNA stuff, it just doesn't exist. And anybody who tells you, oh, they're perfectly safe, you don't know that. I mean, this is such a complicated system that you could imagine something going on along the way. However, let me tell you about these two vaccines. They've been tried on tens of thousands of people, and they are really carefully looking for safety signals, things that are not quite right, a little bit more in this group or in that group, and they just haven't seen it. I mean, you can, in your mind as you're going to sleep, think about the different ways that this messenger RNA could get you, but I think it's going to be safe. But long-term risk, anybody says that we know for sure in the long term that there's no risks is fooling you, because they don't. So Anna asked, our school received Lego STEM kits from a grant. That is great. What's the safest way to use these with kids? Well, the safest way would be to use them in your household. So you work with them. They would probably show you how to use it. If anything, the way my life goes, the kids would show me how to use it. And probably best to have one kid with one set. Now, this virus does not live very well on surfaces. So even if you had one kid use it on Monday, put it away, by Tuesday, the risk to the second kid is going to be infinitesimal. So you could use them for different kids, although, you could clean them in between. You could just wait in between, and I think that would be good. And I think things like the Lego STEM kits are great because these are going to get kids thinking and doing better. So I would like specifics on how our residents are getting COVID. I'd like it in the daily report. Yeah. So, for example, did the 86-year-old man that died attending family social gathering understand this may be an educated guess, but it'll help us personalize what to avoid and incorporate it in our new reality, Darlene asks. Well, so a lot of what we do is tell stories. Right, so if I just say, it's 63.7% more likely, and that's going to just go over everybody's head. But when we tell stories, we can do it. Now, on the other hand, for example, the 86-year-old died, attended a party in such and such. We don't want to get that level of detail because, that could violate some of our privacy concerns. However, let me give you a story. So, a fraternal organization in a rural part of our county had a Halloween party with 50 people there. Photos of the event show that there was lots of mixing and very little mask wearing. Subsequent to the event, we've had we've had an outbreak involving about 30 people from 3 different counties that have resulted in 3 hospitalizations and 1 death. This outbreak has spawned multiple other outbreaks at other businesses in the community that have affected the bank, the city government, a restaurant, a bakery, the harbor, and the city government, and has closed the school because there were so many people in school who were affected. This community that previously had almost no cases, now in the last 2 weeks has had 31 cases, and it continues to spread. So the reason I was a little out of breath when I got here is just before I got here, there were another 4 cases in this community. So I don't know what the number is now. There were a number of 4 cases in the community, some of which are in the nursing home. So what we see then is this decision to have this party, which, they'd had other parties before and other people had Halloween parties, and only, we think, 4 of the Halloween parties had outbreaks. But you have no way to know whether it's your Halloween party is going to be infected or not. And actually, most probably weren't infected. I'm sure there were more than 4 parties around. But when they do get infected, the ripple is incredible. So the ripple from this one party. Now, if everybody had stayed home and watched a scary movie on the couch, which is one of the things we'd recommended, maybe there would have been 2 or 3 people and it wouldn't have spread. But now it's so spread throughout that community that it's going to be really, really, really hard to get this back in the bottle, because it's now in so many businesses and so many other places in the community that it is really high risk. And once it gets into the nursing home, it is so hard to get rid of. So when we talked about Curry, which started off, we think, with just 1 staff member who was ill, and now there's over 30 people who are sick. So we'll try and tell more stories, although I don't think we can specifically link it to, for example, today's death or yesterday's death, but we'll try and tell stories as best we can. So, so I was on a statewide call this morning, and one of the things I heard was that there are people that are not forthcoming with contact tracers for a fear of being that person that gets their schools shut down or other consequences. My question or comment is, you may want to let people know that contact tracers aren't turning anybody in, not get them in trouble, and we try so hard not to do that. We try really hard not to get in trouble. I mean, when people are sick, we sometimes shake our heads like, oh, what were you thinking? But we really, 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 really try hard not to blame anyone for what goes on. I think we just need to be humble in this and recognize that this is a terrible virus. And, we're all human, and we all probably make little mistakes in what we do, and we all have to try to do a little bit better. And if somebody makes a mistake, we don't want to berate them for it or close schools. Really what we want to do is we want to get this virus down. And what we see is that France and Germany and Spain really have done that. I mean, I would encourage you to go on. There's a site called Worldometer, which has very nice graphs. And it gives you the graph of new cases in all these countries. And they struggled with it for a few weeks, put some restrictions in, and have really brought the curve down. We in the U.S. have just not done that. Our cases continue to go up so steeply that what I worry is, again, remember, gatherings lead to cases, lead to hospitalizations, lead to deaths. And I think we've seen the increase in hospitalizations and increase in deaths. I did some math the last week and tried to figure this out. And when I look at it, it's going to be horrible. I mean, unless my math is totally wrong, which it usually isn't, unless my math is totally wrong, it looks like, I don't even want to think about it, but we're going to be averaging over 1,500 deaths a day. Now, I did that about 10 days ago, and we are averaging about 1,500 deaths a day. So my math was right on. The way it looks now, we're probably going to be averaging 2,000 deaths a day, and we actually hit that yesterday. 2,000 deaths a day is a lot of deaths. It's a lot of deaths. All right, so Casey says, how does the Pfizer vaccine compare with the Moderna vaccine relative to freezing sub-zero refrigerator issues? So the Moderna vaccine actually can spend 30 days in a refrigerator, so a lot less than the Pfizer vaccine, which can only spend 5 days out of the super cold. The Pfizer vaccine is going to be complicated because of this cold storage arrangements. But I was in a conference this afternoon, and it looks like we have that under control. So Linda says, are we keeping track of flu cases versus COVID cases? Do tests show only COVID versus flu? Great question. The story is flu is not a reportable illness, so we do not get every report of the flu, although we do follow it in several of our bigger clinics and the hospital that do measure these things. We've still seen very little flu. The tests, there are several different tests. There is one, which is called the BioFire Respiratory Panel, which shows both COVID and flu. Most other places are doing separate COVID and flu tests. Again, we have not seen much spread there. So Zay says, why are we not freezing relief nurseries? So relief nurseries and childcare in general has been a big question about what's going on. Remember, childcare has never been closed during this whole thing, and we have seen very, very few outbreaks in childcare. The other thought is that childcare and relief nurseries are necessary because absent childcare, there are going to be some essential workers who can't work. Absent relief nurseries, we worry about the home situations of those kids. So Catherine says, will we have access to the vaccine that seems to be effective for those over 70? Yes. So again, on part of this conference today, they did how they're going to distribute it. There are going to be two separate distribution arms. One distribution arm, which is going to be handled by pharmacies, is for nursing home staff and residents, and the other one is for everyone else. In the everyone else one, it's going to be spread two ways, one to hospitals and one, again, to everyone else. And so in the first round, they're going to do healthcare workers, nursing home people, and that. After that, which we would hope to be in January, it's going to then go to high-risk people, and the high-risk people are elderly people, people with underlying conditions, and people in high-risk groups. So the hope is that by summertime next year, and I don't think anybody thinks this is going to happen much sooner than that, but that by summertime next year, everyone could get vaccinated. So Patty says, will the flu be lower this year because of masks and social distancing? Don't know. It certainly was lower in the southern hemisphere. You remember the southern hemisphere typically precedes our flu season by 6 months. It was very much lower in the southern hemisphere, again, thought to be related to the use of masks and social distancing. However, flu is really hard to predict, and it might have just been an off year for the flu for some other reason. Will you get the vaccine once it's released? I actually, because I do the swabbing, and I'm up in people's noses who are coughing with this, I will be one of the 1A1 groups, and I will proudly, if I'm eligible to get it, be one of the first to get it. Can you get COVID once you've had it? Patty asks. The answer is yes. And so we know many anecdotal stories, in fact, one now in Douglas County, about somebody who tested positive, was totally well, and now tested positive again and is sick the second time. So we clearly know anecdotally you can get it again. Now, people may quibble, well, are you sure it's a new infection? Are you sure it's not something else? But then there are very elegant studies where they actually have the genetic material from the first and second time that clearly shows it's a second infection. And so, yes, you can get it again. How common that is, don't really know. So Ali says, would you go over how many vaccines we'll get here in Douglas County? Well, I would hope we're going to get 100,000 times 2, right? Most of these need 2 vaccines. So I would hope we would have 200,000 doses. I don't know when we'll have 200,000 doses. What I heard today is that the state is likely to get about 4,000 doses in the first month. So 4,000 doses in the first month. It's going to vaccinate 2,000 people. That would not even cover our nursing home people. So I think it's going to be a little while until the vaccine is more widely available. When we asked the person at the state today at our 2 o'clock meeting, well, can you give us any idea of the future? And he said, it's really hard for me to predict the future. So Linda says, do they know how long the vaccine will work? No. So we do not know how long this vaccine will work. The thought is most of these vaccines, even the least effective ones, still pretty good for a year or so. So it wouldn't be shocking that they decide that after 9 or 12 months, the immunity wanes and you need to get a booster dose. But getting people a booster dose of this vaccine is small potatoes in comparison to getting so many people all vaccinated at once. And the hope would be that if this new mRNA vaccine technology is so great, that maybe we'll even get a better flu vaccine. And that may be one of the best things to come out of the pandemic, is if this mRNA technology is safe and effective, we may be able to apply it to flu. Because right now, the way we make flu vaccines is really old-fashioned. So every spring, if you've ever had chickens, the lights come up and your chickens make an enormous number of eggs in March and April. They take a bunch of these extra eggs, they grow the influenza virus in the eggs until the eggs now have lots of this influenza protein, and then they get the protein out and put it in the vaccine. It's a very, 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 very old process, and the vaccine isn't very good. So hopefully the mRNA vaccine will be better. So Allison says, if we don't bring numbers down, will schools have to close on January 4th? I believe so. So we really need to bring the numbers down. Schools now, all the schools that are open in Douglas County are opening under the previous metrics, and they had the option to either close or stay open until January the 4th. Some chose to close, some chose to stay open. But after January 4th, everybody has to use the new metrics. So if our numbers are still as high as we are now, none of the schools will be open. So how long are the antibodies in our system? Well, antibodies are amazingly complicated. And so your body sees a foreign protein. The T cell says, "Oh, this looks foreign, guy. Let's work on it." And they enlist the B cells, which are the factories then that make the antibodies. Your body has some way of figuring out, looking at this protein and sort of looking at this, I wonder what antibody would block it. And it makes a bunch of antibodies to see which would block it, and then tells the B cells to make that antibody, and then the B cells make a lot of antibody. The first one they make is IgM, which is a very big molecule. And then after a while, they make some IgG antibodies, and those antibodies tend to fade with time. But however, the next time your body sees this, the T cell says, I know, I've seen this guy before. This is the antibody to make. So rather than trying to figure out which antibody to make, it knows what antibody to make, and it can make it in as little as just a few, it can make it just a few minutes. So your body gets the second response, which is called an amnestic response, and it's a much higher, much faster response. So measuring the antibodies in the system is not a perfect way to do it. The T cells can last a long time, and so the T cells last a very long time. So the T cells that recognized my measles infection back in 1963, presumably them or their offspring are still there, and if I got exposed to measles, it would remember it very quickly. So can I speak to why singing is bad? I hate to think of a Christmas performance outbreak, Leah says. I would agree. I mean, I really, really agree that Christmas performance outbreak would be terrible. We do not know why singing is so bad, but it really does seem to be one of those things. It may be that when people sing, because of their incredible breath control, that they're aerosolizing virus as they sing. That seems to be the number one thing. So those of us who talk quietly tend not to do it. But when you hear these people can sing and they can project to the entire room, or in the old days, project to an entire audience, the size of the Jacoby Auditorium, it's just remarkable the talent they have to do that. And it may be the projection of the sound goes along with projection of virus, and that's why singing does seem to be bad. The prototypical one is this group up in Washington where they had a choir practice, a couple of hour choir practice, and more than half of the people in the choir practice got infected. And so we really do worry about singing events. If we follow the guidelines set by the governor and the OHA, how long do you think it will be before we start to see a decrease in numbers? Well, that depends upon how well we follow them. I think if we followed exactly the guidelines there, with smaller gatherings, with social distancing, telework, it usually takes 1 or 2 or 3 incubation periods. So the incubation period of this virus at the maximum is 14 days, but it's typically 5 to 7 days, so let's take a week. So in 3 weeks of working on this, you can really bring this down. And if you look at the curves in Germany, the curves in France, the curves in Israel, it takes about 3 weeks to start bringing it down. So about 3 weeks to start bringing it down. And I think that's the reason the timing was as it was, the hope being that by after Thanksgiving, we're going to start to see the decrease. So Laura says, do you think we're headed for a full shutdown like we saw at the beginning? And the answer on that is no, because I think we know better now. We know better now what are the high-risk activities and what are the low-risk activities. So, for example, salons do not seem to be a really high-risk activity, which is a little surprising because I would think, they're cutting my hair and they're close, but it doesn't seem to be, because I think the salons recognize that they have to use pretty good hygiene. On the other hand, some things that we thought, well, maybe not that dangerous, like gyms tend to be probably a little more dangerous, or singing events tend to be more dangerous than we knew before. So I think this freeze is a little bit more surgical, in that it looks at the high risk things and at the low risk things. And I hope we're not ready for a full shutdown. I mean, that was really, really, really hard on businesses. And the first time around, there was CARES Act money. People maybe had money in the bank. At this point, not so much. And that's why we're hoping not to do this. But if people really did the things that are in here, don't go to restaurants, small gatherings only in your household, do takeout rather than eating at restaurants, telework if you can, avoid travel. I really think within 2 weeks, we could both hit the peak and start to bring this down. And because it will go away, right? We know that once we start to identify a case and we can get our hand on all the secondary cases, it usually peters out. So, we've had a lot of outbreaks over the time, hundreds of outbreaks over the time. And most of them, if you get your hands around them, are gone in 1 or 2 or at the most 3 incubation periods. The problem now is there's so much disease in the community, you have no idea where this is coming from. So in this small coastal community I talked about, we could find the first case, we could find their contacts, and we could find their contacts. Well, now we're one more generation out, and there's all these people who are probably related to these other cases, but it's so hard to know because there's so many different contacts along the way. So, have you ever done a family tree? Once you start to get down the 4th or 5th generation, there are so many people out there that trying to figure out who they're all related to makes it very, very hard. So Stephanie asks, is our hospital prepared to take on the increasing COVID patients, or will they be transferring any serious cases to Eugene or surrounding hospitals? So Mercy right now is not doing badly. They have about a dozen people in the hospital, about a third in the ICU, about a third in the PCU, and about a third on the floor. It varies day to day, but that's typically the thing. They have some patients who need really high levels of care, like something called ECMO. Those patients get transferred to Portland. They sometimes need other higher levels of intensive care, and they get to Eugene. But Mercy does a dang good job in treating these patients, and so I don't think that's going to change. Casey says, how are the doppelganger communities doing right now compared to us? Really not great. So I looked at the doppelganger communities. You'll remember back in August, back when there were very few cases, we looked at other kinds of projects. And one of the projects we looked at was to look at 3 other counties in the U.S. who are very similar to Douglas County in different states that had much less restrictions than in Oregon. And so Douglas County, about 100,000 people, doesn't really have a big city in it. It's on a freeway, has a small college, and has a mixture of manufacturing and resource extraction and farming as its major industries. Income levels around 40,000. And then we also picked Twin Falls, similar in a lot of ways, near a freeway, nothing particularly remarkable about it, but Idaho has a lot less restrictions. The other one we picked was Pennington County, which is where Rapid City, South Dakota is. Again, Rapid City, that county about the same as ours, a little different, and they have more military and more Native Americans. And then Lowndes County in Georgia, again, remember Georgia's had very little restrictions. That community has more people of color, has slightly lower income, but actually has less disability in it. So what we look at in those is how many deaths they've had and how many cases per day. So we feel like we're drowning. I collected these at the beginning of the week. We feel like we're drowning at 18 cases per day. Twin Falls has 113 cases a day. Pennington has 153 cases a day. And Lowndes has 33 cases a day. So many, many more cases than we have. And overall deaths, at the time we'd had 12 deaths. Twin Falls had 68. Pennington had 59. And Lowndes had 122. So we have 12. Lowndes had 122. So the doppelganger counties are doing much worse than we are. I don't know how they're doing it. I mean, we're barely hanging on. And I'm not sure how we could handle 10 times as much disease or 10 times as many deaths. So what precautions should an essential employee make before coming home to a spouse with a compromised immune system? Jennifer asked. Now, the good news we know is that this does not seem to be particularly contagious on clothes or on boots or things like that. But I think what many healthcare workers do, and it's just not COVID, it's other kinds of stuff you deal with too, come home, take your shoes off, take a shower, get in clean clothes. You should be perfectly fine. So Heidi says, if somebody gets the vaccine, how long will it be before they're protected from COVID? These cases they looked at were after the second dose. So you had to get your first dose, you had to get your second dose, and then they looked at cases after the second dose. So we think after the second dose, it's already starting to be active. So Chelsea says, if somebody tests positive and works at a restaurant, what does that place have to do to or with employees that work with them? So Chelsea asks. So at a restaurant, this is very complicated because restaurants, there's lots of movement around. I'm always impressed at how much people in restaurants work. So in restaurants, we would use the typical time and distance criteria. So if you were within 6 feet for more than 15 minutes, then we would consider you a contact. So let's say you were the two guys or two people on the cook line, and you were standing next to each other doing it. You clearly were within 6 feet for more than 15 minutes, and then that contact should change. Now, on the other hand, if the person who has it is a waitress, does the cook need to do it? Well, again, you have to say, was I within 6 feet for 15 minutes during the shift that I worked while I was sick? And so this is all very, very specific to the deal. Restaurants do not need to close down if they have a single infected employee. Although you could imagine a restaurant like let's say it was a food truck. If one of the people in the food truck had it, likely the food truck would have to shut down. So how are treatments working? Is there a medication you're given while recovering at home? Sarah asks. There are no medications for giving you when recovered home. So let me go through all the different things. So I've been a big baseball fan, especially when I was a kid. And so, we've talked about these things as different things. So remdesivir, which is out there, it's an antiviral drug that was originally developed to treat Ebola and was found to have some effectiveness on COVID. It doesn't seem to make any difference in mortality, but it does seem to shorten the length of stay and shorten your time in the ICU. So I've called that a bunt single. So you'll never turn down a bunt single, and we use remdesivir, but it's certainly not going to win you very many games. This week, the WHO came out and said remdesivir has no mortality benefit, and I think everybody agrees that it doesn't. And because of that, they're not recommending it. We are recommending it in the U.S. because in the U.S. it does seem to have some decreased length of stay, which is always a good thing. Anytime in the ICU, 1 or 2 days less would be a good thing. There's the monoclonal antibody that was made by Eli Lilly that's been approved. This monoclonal antibody works on people early on in the disease. It was originally developed to be used in nursing homes. Imagine you have a nursing home outbreak. You find people very early because you're doing a lot of testing. You find people who have it early at the very onset of symptoms. You'd give them a dose of this because they're already in a medical setting and do it. It's also been released for outpatient treatment, and nobody exactly can figure out how it's going to go. It does not seem to have any mortality benefit That is, it doesn't seem to decrease the risk of death, although then I've tried it on very many people, so it might, and you just may not have been able to find it. But did seem to decrease the rate of you need to go into the emergency department from 6% to about 1.5%, so about a fourfold decrease in the risk of needing to visit the emergency room. Well, that's good, because I don't want to visit the emergency room, but it means that if you give it to 100 people, for 94% of the people, it doesn't make any difference at all. For 97% of the people, it makes no difference at all. For that group, that goes from the 6% to the 1.5%, it does. So it's okay. It's a single. It's a ground single. The next one is Decadron. So Decadron, which is a steroid, seems to decrease the inflammatory response. It's given sort of the middle part of the disease, and it does seem to reduce both mortality, length of stay, and so it's what I call a solid single there. Hydroxychloroquine, I'd love to say it was effective, but it's a strikeout. Azithromycin is a strikeout. However, the vaccines, they are a home run with men on base. I mean, they came in better than you'd ever thought, and those really will win the game. So home run with men on base is what wins games, and so the vaccine is a home run with men on base. So is there a medication you're given while recovering at home? Some people will get Decadron at home, but for the most part, not. Amy says, what is the time frame for the second dose of the vaccines? They're typically given about a month after the first one. We are not sure on the EUA what the time frame is going to be. It's going to be at least 2 weeks, and I think it's going to be less than 6 weeks. But I don't know if it's going to be 2 weeks to 6 weeks, 3 to 5 weeks, or exactly 4 weeks, which is going to be the time frame of the second dose. That's going to make it complicated, right? Because as we do that first group of patients, you give them their first dose, a month later, you're not only going to be giving the first dose to a new group of patients, but you also need to get the second dose to the first group of patients. So it's going to really be a hard vaccine challenge. Think about how many vaccines we need to give, right? If we're talking about getting rid of this when 60,000 people in Douglas County are immune. So to get 60,000 people in Douglas County immune, you need to give about 70,000 people, because of the numbers. You need to give about 70,000 people 2 doses of vaccine, 140,000 doses of vaccine. So let's compare this to what we've done in the past. So, we've had these flu drive-ins, and we're so great. We're the best in the state, and we are when we do it. We give 150 or 200 vaccines. 150 or 200, we're talking about needing to give 70,000 people 140,000 doses. So 700 times what we've done already. So it really is a tremendous, tremendous number of vaccines that we're gonna need to give, and that is going to be really a gargantuan effort. Now, it's going to be tough for everybody, but if there's any county that's used to doing it, it's us. I mean, we've done over 90 drive-through COVID testing. We've done half a dozen at least of drive-through immunization clinics. And so we know how to do it about as well as anyone. And people think, oh, we'll just set this up. It's not just setting up. It's like setting up a wedding. Anybody who's ever set up a wedding, you wouldn't say, oh, it's just a wedding. I mean, these are complicated things with thousands of details to get through. All right, so I'm getting the boot here. It's 5 o'clock. So let me give you a couple of other things along the way. A couple of new things that came out is that with this, they're starting to see people, especially older people, who present with COVID with their only symptom being delirium. Not any of the other COVID symptoms. They're just sort of out of their mind, and they come to the emergency department and they're tested and they have COVID, and then later on develop the typical COVID symptoms. That is concerning. And then we'll do the rest of it. We'll do the rest of it the next time. Okay, so a couple of things. Thanksgiving is coming up. The CDC yesterday made recommendations not to travel. I couldn't agree more. I mean, really, when we saw the huge increase in cases resulting from Halloween parties, I can only imagine what the increase will be with Thanksgiving. So I'm actually pleading with people, keep the gathering small. And the gathering should be, at best, should be your household and then not others. That's what we're going to do. We're going to call everybody and wish everybody well, but we're not going to have a big gathering. And we would recommend that people don't have big gatherings. When you're out, please wear your mask. If you're going to travel, please quarantine when you get back. All of those things, I think, could help us to bring it down. So our Facebook schedule for next week, we're going to do Tuesday, and on Tuesday we'll tell you what our schedule is for Friday. I'm working Friday. There's a funny story about what I'm going to be doing Thursday and Friday, but I'm going to be working Thursday and Friday, but I'm not expecting everybody else to work, so we may figure out a way to do it otherwise. But we will be here on Tuesday, so we'll go ahead and do it Tuesday next. Again, there's been some real ugliness going on this week. I've seen such terrible notes that people have written to each other, all in caps, lots of punctuation, lots of cursing. Please, we don't need to do that. There's stuff we can disagree on here, whether schools should be open or not open, what rate they should be open at, what protections we need for teachers or students. Those are all tough things and all things we can discuss. But when we yell at each other and curse at each other, I think our ability to go ahead and learn from each other just goes out the window. So please be kind and be safe and have a safe Thanksgiving. Again, this is Dr. Bob Dannenhoffer, Public Health Officer of Douglas County. Bye-bye.